Good afternoon, everyone. I'm Amanda Nelson with the Office of Aging and Disability Services. Today, in addition to our presenters, I'm joined by my colleagues from DHHS, Maine Healthcare Association, and Maine's Long-Term Care Ombudsman Program, who have joined forces to support nursing facilities through quality improvement initiatives known as QuEST. Quality, excellence, staffing, and teamwork. As part of the new nursing facility reimbursement program, nursing facilities have an opportunity to earn a share of $8.1 million quality bonus pool through a new value-based program made possible through the Nursing Home Transition Fund. In 2025, payment is based on participation in quality improvement initiatives rather than on performance. Today's QuEST call counts towards your facility's 2025 participation requirements. In case you missed it or need more information on the QuEST partnership, please email odes.nfquality@maine.gov. It's great to see so many faces on our call. To ensure you get credit for your attendance today, we ask that you turn your cameras on and add your name and the nursing facility you represent into the chat. This is especially important if you are the designated quality champion. This meeting is being recorded. The recording, as well as the slides, will be posted to our rate system reform website and will also be distributed to QuEST members via email. If you're not already receiving those updates, please just email odes.nfquality@maine.gov. And Chelsea will drop that email address into the website as well as the rate reform site. You may also send a request if you'd like a copy of today's chat or attendance log. Our goal is to share information, but also to hear from you, our local experts, on some of the best practices that you're implementing. First up today, we'll hear from our national CoreQ experts right after Olivia gives a brief snapshot from DHHS. And then after our national CoreQ experts, we'll hear a little bit more from Olivia around how CoreQ fits into QuEST and VBP. Finally, we've left 15 to 20 minutes as usual at the end to hear from you, your thoughts, your ideas, your questions. So before we get started with the CoreQ presentation, I'd like to hand it over to Olivia Alford from the Office of Maine Care Services to give a little preview of CoreQ and the VBP program.
Great. Thank you. Hold on one second. Okay. Hi, everyone. My name is Olivia Alford. I'm the Associate Director of Delivery System Reform at the Office of Maine Care Services. So I just want to give just a reorientation to how the conversation today fits into the quality bonus pool requirements that Amanda started to mention. So we are currently in year 1 of the quality bonus pool, where it's paid for participation. And Amanda mentioned this, participating in this event is one of those things that will lead to a qualification for your portion, your nursing facilities portion of the quality bonus pool for 2025. But the content for today is CoreQ, which is the patient resident family experience survey, which is actually going to become a requirement in 2026, so year 2, when we're actually going to be looking at nursing facilities meeting minimum standards for how they score on our quality measures. CoreQ is the 3rd quality measure that we talk about in what will be scored for year 2 and year 3. You've already started receiving reports on the other 2 quality measures in this program through scorecards, just for your information, as how your current data shows that you are doing compared to national benchmarks. But again, CoreQ hasn't come in yet because we're just really, with this call, starting to kick off the process for you to start knowing more about what the requirements are going to be for CoreQ, so you can prepare for 2026 and beyond with your CoreQ requirements. And like I mentioned, we'll come back at the end, like Amanda mentioned, we'll come back at the end to talk more about how CoreQ, after you learn more about it from our experts today, will fit into the nursing facility payment reform work. So I'll hand it over to Nick.
Thanks for that, Olivia. I know we'll know more of those details a little bit later on, I'd like to introduce our presenters for today. We have Dr. Lindsay Schwartz, who is a nationally recognized expert on quality and workforce in LTSS. In 2022, she launched her consulting, advisory, and research firm, Workforce and Quality Innovations. Prior to launching WQI, Dr. Schwartz was an associate vice president of workforce and quality improvement for the American Healthcare Association National Center for Assisted Living, or ACA-NCAL. Dr. Schwartz earned her PhD from the Johns Hopkins University Bloomberg School of Public Health in the Department of Health Policy and Management, and prior, her BS in psychology and a minor in business from Indiana University. Dr. Schwartz has a long history in home and community-based services, including as working as direct care staff and as a case manager for an area agency on aging. We also have with us Dr. Nicholas Castle, who is a leading expert in long-term care with over 230 peer-reviewed publications to his name. He serves on 6 editorial boards, including The Gerontologist, where he is also the international editor. Dr. Castle is a fellow of the Gerontological Society of America and has been recognized for his contributions to nursing home quality with prestigious awards from the American College of Healthcare Administrators, including the Long-Term Care Researcher of the Year Award in 2001 and the Public Service Award in 2011. Dr. Castle has extensive experience collecting data in long-term care settings and is highly regarded for his work in instrument design. Over the past 15 years, he has developed a range of survey tools focused not only on satisfaction of residents and family members of long-term care settings, but also tools to gauge job satisfaction of nursing home administrators and nurse aides. He was a key contributor to the CMS-funded Consumer Assessment of Health Plans Study, or CAHPS, and also one of the developers of the QuEST survey. He is also a frequent presenter and technical expert panel member for numerous CMS initiatives, including Nursing Home Care Compare and the 5-star quality rating system. With that, Dr. Schwartz and Dr. Castle, we're honored to have you here today.
Thank you. Hi, everyone. I'm going to go off the video before I start sharing. Thank you all for being here. I know everyone is busy. Are we good? Okay. So we wanted to,
We can see your slides, Dr. Schwartz, but it's not in presentation mode, just so you're aware.
yes, there we go. Can you see them now in presentation?
Not quite.
Huh. No? How did this work last time? Okay, hold on. Can you see them? Are they in slide presentation?
Yes.
Okay.
Yes, we can see them in the right view.
Always. Okay. So, like Amanda said, we're going to talk about CoreQ today, dive into how we developed CoreQ. Nick and I were on the team that developed it. We're going to do some poll questions to kick it off first. We're going to talk about outcome measures that are important, which includes customer satisfaction, and then just really do a deep dive into CoreQ, talking about brief on the background and development, but we think it's important just to know a little bit about that. And then talking about who's eligible resident-wise and family member. We will walk through the CoreQ questions that you all will be using and how they are scored. And then I just have real briefly how to improve your CoreQ response rates. So kicking it off, we have some poll questions we would love for you to answer.
So this first one I want to emphasize is about a resident satisfaction survey.
We'll give you all a minute to respond.
All right, going to close the poll in about 3 more seconds.
I can't see the poll. Is it supposed to be on the screen or?
It is supposed to be on the screen.
Yeah, I don't have anything.
Can everybody else see the poll?
Yes.
Yes,
Yep.
okay.
Yes.
Okay, we've got almost everybody answered. I will wrap that. And we'll share the results. And hopefully you'll be able to see the results.
Oh, this is great. Okay. 7% core Q. Oh, that's great oh, so almost 50% of you are already collecting resident satisfaction between core Q and another method. Wonderful.
Ready for the next one?
Sure.
All right, this one is regarding family satisfaction specifically. Okay, results are slowing down. We'll give it about 3 more seconds. Okay. And here's the results of this one.
Oh, this is good. Little lower than resident, but that's great with family satisfaction. And for those of you that don't collect family and resident satisfaction, this is exciting. You have a chance to do that and improve, hopefully work on improving satisfaction, because we'll talk about why it's so important. That was our last one, right, Amanda?
Yes, it was.
Just making sure. So why is satisfaction important? Everybody, I don't know about you guys, but wherever we go to eat, we always look up reviews, hotels, doctors now. This is a local place that has the best barbecue in our little rural area. Facebook reviews. And as a nursing home, you guys really you may be on Facebook already, but it's good to check reviews, because people will absolutely leave reviews on Facebook about medical, nursing homes, farms, everything when businesses are on Facebook. TripAdvisor, Yelp, all these have really made satisfaction important. And then I'm in North Carolina. UNC has satisfaction. As you can see, this is my lovely primary care physician, and she's highly rated. But I even go and look up specialists and everybody else that I'm going to see. And you may not be on Yelp for your nursing home, but sometimes people can start Yelp and a review, and the same thing is with Google. A place for mom. We see a lot of nursing homes, assisted living, and other long-term care settings, caring.com, and just a bunch of other places. It's really become more important about satisfaction. I even go check Amazon reviews if I'm in like Lowe's and I want to see something I'm buying, what the reviews are. So if people are doing this with going out to barbecue or staying in a hotel, they're of course going to want to know how good your nursing home is, and if residents are satisfied, if family members are satisfied. It's really an indicator, and we'll talk about that, of overall quality. So why is satisfaction important? Residents and family, as I just mentioned, and Nick's done a lot of this research, it is highly associated with quality outcomes, including CMS 5-star and turnover. Resident and family satisfaction is important to providing person-centered care. I can't think of anything more person-centered than providing high-quality care that your residents and their family members are satisfied with. And it's also important for working with other organizations. I know just from doing all this work with Nick in the Core Q, but also working at ACA NCAL and working with different types of organizations like managed care organizations, hospitals, talking to assisted livings and skilled nursing facilities and nursing facilities, finding out that they were being asked their satisfaction score from hospitals that they may work with or their residents may go to and then come back to the skilled nursing facility. I've had calls with investors that have asked, what metrics they should look at. And we talk about the, clinical ones, falls, hospital readmissions. But then I always talk about staff turnover and retention and customer satisfaction. They're just always really important. And people know typically if you don't have good satisfaction, the care is probably not good. Just because, like I said before, it is associated with quality outcomes. High resident and family satisfaction, you can also use as marketing tool. Really set your nursing facility up from other providers when you have great scores. Okay. So Nick and I have been working on Core Q since 2012. We started doing this. We had a member at ACA NCAL that was really not happy with CAPS. Sorry, Nick. They're good surveys. They're just long. And so Nick and myself, Dr. David Gifford, who is still at ACA NCAL, a handful of members and some vendors, customer satisfaction vendors. There were 3 in the very beginning that worked with us, and we developed the Core Q. Nick and one of our colleagues, Matt, who was getting his PhD, they both did extensive research and analyses for us to get to these 3 or 4 questions, depending on the survey. So what is Core Q? I'll go back to that before we dive any more. It's a set of 5 measures. So they're for skilled nursing facilities, and assisted living communities to assess satisfaction among patients, residents, and family members. There are 5 surveys. So we have 2 for assisted living, 1 for resident, 1 for family members, 1 for SNF short stay residents, and the same that goes with assisted living. For nursing facilities, we have long stay residents and long stay family, which I'll talk about how we define long stay. So I mentioned that our members, we were working on and if you are a Maine Healthcare Association member, you will know about the quality initiative that we launched in 2012. And one of those 4 goals was customer satisfaction. And we had members come to us and say, we would love to benchmark across, different satisfaction vendors, but we're unable to because my satisfaction vendor asks a question one way and my neighbor's satisfaction measure asks the question just a different way or uses different scales. So response options. So some might have 4 response options, some might have 5. When you have that, you can't compare. It's not apples to oranges, but apples to apples, maybe like a, Fuji apple with a pink lady apple. They're in the same family, but they're not exactly the same. So, as I mentioned, we had a team of providers, satisfaction vendors, and Dr. Castle, and to develop the Core Q. And I don't remember how many years that took, but it took a number to really work and make sure we had a good solid measure. We developed a 3 to 4 item questionnaire for creating an accountability measure, so public reporting. So like I mentioned for SNFs, NIFs, and ALs. We did develop a short satisfaction questionnaire that I think it's 15 items to help the facilities do quality improvement. So this is more of, since it's short, just overall satisfaction. But to do quality improvement, you really need to ask additional questions. So to identify questions, our team, Nick ran focus groups and cognitive testing with residents, staff, and family. He did an extensive review of existing satisfaction surveys and developed pilot questionnaires. And so we worked closely with providers and satisfaction vendors to understand what worked and didn't work with satisfaction surveys and response rates. This was really honestly, and Nick, you could pipe up if you agree or disagree, but this was to me one of the most collaborative process to develop a measure that I've probably ever worked on, including satisfaction vendors and providers and families and residents and staff. It was just really nice to see that collaboration and work together. And I feel strongly that that's why it makes the CoreQ good. We had all the stakeholders at the table helping out, and it was quite a learning process too, in helping some of our satisfaction vendors learn, some best practices that maybe they hadn't thought of in regards to how often they were doing satisfaction surveys or how they were calculating some of the response rates. We reviewed and had extensive talks with the satisfaction vendors about inclusion and exclusion criteria for residents and family on similar surveys, because we didn't want to go too far away from what was already being done. We wanted to do what was quote unquote normal, or used to be what the current satisfaction vendors were doing. So we tested validity, which is accuracy of the measure, and reliability, the consistency of the measure. So is it measuring the same thing over and over time? And again, Nick did, and our colleague Matt did extensive data analyses, and the CoreQ was correlated with important quality measures. So 5-star and turnover, and we've done some work with assisted livings, but we're just focusing on nursing facilities today. But we have a lot of analyses too on assisted living. So CoreQ is being used in many states. Most states it is like what you guys are going to do, a value-based program. And there are some states that are using it for assisted living. Minnesota now has a report card. Oregon has started collecting satisfaction, and it is also optional for Wisconsin. They have a really great quality program for their assisted livings called WIC-SEAL. Washington was looking at it pre-pandemic. I just like to think that they're still pending and thinking about it. Of course, some of this had to stop due to the pandemic, but a lot of the states have picked this up, as you can see, back up if they maybe stopped it temporarily. And then there is possibly CMS in the future short stay. I don't know if there's Nick, I don't want to put you on the spot, but is there any update?
No, that's still on hold.
Okay.
Ended.
Thank you. That's been an ongoing process. But we hope that one day it will be on CMS, one of the quality measures that's publicly reported. I have good faith that it will one day be there. One of the really important things we wanted to do with the measure with CoreQ was get what's NQF endorsement. So the National Quality Forum, which has now, that is who CMS contracted with for a very long time, and now CMS contracts with Battelle. Endorsement is considered gold standard of measures and informs use by CMS and other programs. Once we had our questions, we collected data to submit applications for NQF endorsement. We first did the nursing home ones because we had easier access to data. AL took a little while, but all 5 CoreQ measures received endorsement from National Quality Forum, and the AL CoreQ measures were the first AL specific measures to receive endorsement, which was really nice. NQF endorsement is very, I don't know how, Nick, you feel, but during the calls where you are on with measure developers and those that are going through your assessment, it felt a little bit like my dissertation committee. So it is a very thorough process, or it was with National Quality Forum. I've heard it is the same with Battelle. They really want to make sure these measures are good and stand the test of time, but also, are fair, aren't excluding people unnecessarily. And so I think Nick is in the process still of the re-endorsement for the assisted living measures. for ACA and Cal going through Battelle, who will endorse those. So they'll be re-endorsed. And I think it's, Nick, has it changed? I thought it was every 3 or 4 years there's a re-endorsement.
Yes, we just submitted paperwork with them this year. We have endorsement for 4 more years.
Oh, that's great. Congratulations. So they keep it up. You are expected to have new data when you come up for re-endorsement. So it's really nice, and it is like a great stamp of approval to have for a measure. So your eligible residents and family members. So it's easier to go over exclusion criteria than inclusion. So residents who meet any of the following are not eligible for the core Q. So residents on hospice, and the same thing goes with their family members. We all felt pretty strongly we didn't want to impose upon them. There's also a CAPS that asks about hospice services, and just felt it better not to do that. And that was also, I believe, the customer satisfaction vendors, an exclusion for them too. So long stay residents are there 100 days or more. So any resident who has been in this NIF less than 100 days is not included. And then a BIM score on the MDS is 7 or lower. Just a quick note, because we've had questions about this before, Core Q can be administered to residents regardless of their pay status. So if they are private pay, covered by Medicare and or Medicaid, but for your work, it sounds like it's all Medicaid long stay. So just so you have an idea, if you use Core Q outside of the VBP, or test your other residents too, or include them. Not for the VBP, but overall satisfaction. If a resident is not eligible, their family member may be eligible, so it doesn't take them out. And the same goes for if a family member is not eligible, it doesn't mean the resident isn't eligible. And a resident and family can both fill out their respective surveys as long as they're from different perspectives, and they're important perspectives. The exclusion criteria for family members. So any family member that meets any of the below criteria, they are not eligible. So again, if the resident is on hospice, if the resident has been in the nursing facility less than 100 days, if the family member lives in another country, if they are a court-appointed guardian, typically and I know there's always differences, and sometimes court appointed guardians do know a lot about the individual, but we kind of had to be consistent. So they're not eligible. And as I mentioned before, if a family member doesn't meet the eligibility, say they live in another country, but the resident is eligible, the resident can still complete the resident survey. And when we were talking about this presentation, there was a great question. What happens if a resident returns from a hospital after a stay, whether it's 3-day or 5-day, are they eligible for the Core Q? And the answer is yes, both the resident and family member would be eligible as long as the resident had been at the nursing facility for 100 or more days prior to the hospital stay. So that hospital stay does not make them ineligible. And as long as they meet the other criteria, as long as they're don't have a BIM score of 7 or below, they are absolutely eligible. So Core Q questions in scoring. So all the surveys, the 5, have the same first 3 questions. And they're slightly different, worded just differently for the family members. But number 1, in recommending this facility to your friends and family, how would you rate it overall? That is a pretty standard question across all satisfaction vendors. Overall, how would you rate the staff, and how would you rate the care you receive? Assisted living residents have an additional question about food. Short stay has an additional question about how well your discharge needs were met. These came out significant when Nick and Matt were doing the data analysis, excuse me. And what was interesting, I mean, because we all know, I think food comes up all the time, that food wasn't it wasn't significant to be added to the nursing home, the nursing facility one, so long stay residents. They all use the same scale. It is a 1 through 5 scale, with poor, average, good being the middle, very good and excellent. These are pretty similar to what similar to what the other satisfaction vendors have, but Nick, correct me if I'm wrong. I think you analyze like 10 different scales.
Yeah, we looked at the scales to see what was being used, what was understood by residents and family, and which worked well with reliability and validity, and which one the vendors in the nursing home industry themselves actually felt comfortable with, and that's how we came up with this scale. It performed very well on all of the above.
Awesome. Thanks, Nick. So a lot of analyses and work went behind this. So it is a good measure that is widely accepted. The CoreQ family measure, these are the slightly different worded questions. Again, the same scale. So this allows for ability to be able to, when 2 facilities or more are looking at satisfaction, it allows them to compare. Now, I will say, and I always say this when we're talking about CoreQ, if the idea is for you to improve your satisfaction scores, you will need additional questions. Obviously, the food one for assisted living can say something about food, but the others, it's just not enough information. You have to, dig through. It's like peeling an onion back, figuring out what you need to improve upon. So you need additional questions. As I mentioned before, we have additional questions that tested well. If you work with a satisfaction vendor, sometimes they have questions they can suggest or recommend, or you can choose from. The additional questions are not included in your CoreQ score, and they should not be included in your CoreQ score. And CoreQ should always be the first questions in the order that I showed on the previous slide and grouped together. So the reason we say that is because that is how they're tested. Not all satisfaction vendors do that, which we understand. They have also done extensive analyses to make sure their surveys are reliable and valid, but it's really important when you're looking at CoreQ to have it be the first set of questions, if possible, and that they're grouped together in the same order and they have the scale that's used. So the CoreQ scoring, when you get a score back, it is the percentage of individuals who are satisfied. So and I'll go through this visually too. I'm a visual person. The number of respondents for each survey with an average score greater to or equal to 3 are counted and divided by the total number of valid responses to the survey. And I will also talk about what is a valid response. So a scoring example would be if your nursing facility had 25 resident respondents and they had valid responses. Of those 25 respondents, 20 residents scored your nursing facility a 3 or above on the CoreQ. So your resident CoreQ score would be 20 divided by 25, which is an 80% satisfaction rating or CoreQ score. So I feel like it's gotten better about missing data. I don't think we have a lot of missing data. Correct me if I am wrong about that, Nick. But we wanted to make sure we had something to use if there was data missing. So if they are missing one question, it is a short survey, so it can't be, more than one. We just take the average of the other 2 or 3 questions depending on the survey. If more than one is missing, it is not included. So it is not a valid survey. So that would be a survey that would not be included in your CoreQ score. So one of the things that's really important in any survey, but especially CoreQ, is a minimum number of responses and a response rate. So NQF had requirements, and I'm sure Battelle has the same. It's pretty standard, but a minimum number of responses. So in research, we call it sample size. It can impact the accuracy and representativeness of the sample. So if you have 4 residents, one resident has a lot of power for that core Q score. They could really drive it up or really drive it down. So that's why a minimum number of responses and response rates are important. So you want as many residents to complete the survey as possible. We'll talk about the minimum number of responses and response rate and how we improve those. Minimum response rates ensure reliability and they reduce the risk of response bias. So just like I was saying, if someone, we know in general, people that complete satisfaction surveys are usually on one end of the spectrum or the other. So they're very happy or they're very unhappy. So it's important to get a number of surveys to really see a full picture and not just have the people who are very unhappy or very happy, drive the score. So for the minimum number of responses for Core Q, we recommend, and it is in our manual, the technical manual, a nursing facility should have at least 20 valid response surveys for each group. So resident and families, you want 20 residents and 20 families. And I know you may not have that many residents, and Maine is working through this, so they'll be able to fill you in later on. And what are valid responses? As I mentioned before, their all core Q questions are answered or only missing one question. For nursing facilities with less than 20 residents, we always say your goal should be to have all residents that are eligible complete a survey. But again, you may have different rules for the VBP program in Maine. So minimum response rate, nursing facility should have at least a 30% response rate. I know that probably sounds low in research, that's high. But again, this is separately for resident surveys and family surveys. So resident surveys, a 30% response rate, and family surveys, a 30% response rate. You don't combine those. As I mentioned, valid responses where core Q questions are answered, except only if one is missing, that's okay. And your goal overall, I always tell people, should be to get the highest response rate possible. 100% would be great. And we have seen that in work that Nick and I've done, but it's usually not that high. So that's not unusual. And then I want to walk through response rate calculation because I think it's important just to understand where we get that. And I use 100 residents because the math is just easier doing that. So if you have 100 residents, 25 that met that exclusion criteria, so maybe BIM scores or they were on hospice, they're not included. So 75 residents are sent a survey and only 35 residents complete the survey. When they're returned, they have 10 surveys that are excluded. So maybe they're missing 2 questions or someone helped them fill it out. And so you end up with 25 residents with usable surveys. So you'd have the number of valid surveys, which is 25, divided by the number of residents or family members who receive the surveys. So in this case, it's 100. And you'd have a 25% response rate. That is wrong, actually. It'd be 25 divided by 75. Right, Nick? I just realized that. Yes. Okay. So what can you do to improve your response rate? You can share the letter we sent with family and residents, post the letter where residents and families can see it, include it in a newsletter or announcements that you may have. Make sure staff know it's important for residents and their family members to complete the survey. So if they see family or are interacting with a resident, they can remind them, hey, don't forget to fill out your satisfaction survey. What you don't want, and I'll just say this, is staff like standing over or helping residents fill out a survey. They should not do that. They can help them if they need help, like folding the survey back and putting it in an envelope. If they need help physically doing that, that's okay, but not help answering the survey. And that's all the slides I have.
Thank you, Dr. Schwartz. Thank you, Dr. Castle. That was really great, especially for those of us who haven't heard a lot about CoreQ so far. I want to hand it back over to Olivia for a minute to share a little bit more information from DHHS and the VBP program.
Okay, great. And while I'm talking, please think about the questions you have. So what we're really fortunate about doing it this way, or with this timing again, where we're working towards a requirement for 2026 right now, is that we have a really good window of time right now to have this conversation with the experts here about the CoreQ, what it is, how it is administered, and then receive feedback, which during this call, but also after this call, which we'll talk about questions you have or how you could see this working within your facility or your organization. So I'm gonna just raise a few points that we have already received in questions from facilities or others that we think will be helpful as you think about what questions, concerns, or what excitement you have about this work, and then we'll open it up for those conversations. So in general, the department is really looking to align with the user's manual, the technical specifications that the developers of the tool have put forward. You heard those just recently from Dr. Schwartz. So we are going to be proposing at this point that surveys are completed by mail. You may hear vendors have other formats of collecting data, such as text or phone calls. Right now, where we're talking today, we're thinking mail, including residents and families who have been there more than 100 days. Again, what Dr. Schwartz just said. We actually are open to this idea of all payer types or all insurance types being included in the survey. So your facility could survey all your residents, not just your main care residents, and then we would use those results. So we're comfortable with that, and that's really where we're starting from with our thoughts. Again, allowing facilities to add additional questions so that they get the most out of this effort. You would be choosing your own vendors, and we anticipate some more questions about that, but just to set the groundwork that department is not telling you who you need to contract with to do CoreQ in your facility. That will be up to you. We will require that results are uploaded to the American Healthcare Association National Center for Assisted Living Long-Term Care Trend Tracker, or any other department designated database, so that we can make sure that we have the results available to benchmark against a national data source, that your results are included in the national data sources, I should say. And then reminder that, as I mentioned before, we're talking about this for 2026 in the context of scores being evaluated against a minimum threshold, which we're thinking would be about the 20th percentile of a national data source. So again, setting the bar on the lower end for all measures in 2026 to just make sure that there's movement towards meeting a minimum threshold in order to qualify for that quality bonus pool. And then in future years, that starts to have a greater incentive tied to higher performance. But really at the beginning, we're just talking about meeting a minimum threshold for performance. So I think, Amanda, do you want to turn it back to you to open it up for some questions now? Or you can remind me what we're doing next before I keep going in the slides.
Yeah, sure. We can open it up to questions now. So you can just feel free to come off mute or put your question in the chat. If you want to raise your virtual hand, you can do that with the React button at the bottom of your screen. Just as a reminder, if you're joining by phone, to raise or lower your hand is *9, and to unmute and mute is *6. So what questions do we have so far?
Yeah, so one in the chat. And again, I want to reiterate, this is what we're thinking now. Part of it is that we also want to hear your reactions to what we're thinking or what I just presented. So would non-main care surveys count towards the minimum? At this point, we're thinking yes, because again, we know there's some small facilities that are going to need to meet those minimum requirements, and we want to make sure you're looking at your whole, all of your residents.
Yeah, I do have a concern because I have a lot of hospice patients in my building at this point in time. And it seems like it's a large push to put more people on hospice lately. And those people are excluded. And even though many of them could probably answer the survey questions just fine. And so I'm concerned about not having enough to even hit a mark, and get a, is the measure going to be based on family and residents as a combined entity, or is it just going to be based separately? Like, I think that's the concern I have is how do I know if I don't have enough eligible people on the resident side, but I have enough eligible people on the family side? When you talk about not being there for 100 days, excluding people with certain BIM scores, excluding hospice people, you do tend to remove quite a few people in a small 65-bed facility from the pool of potential people you can get back, and then getting those people back is a concern for myself. It just, how will that reflect in the scorecard, for me, with all those barriers, which I do see at the moment with the current population, which could change, and then again, the next question would be, how often are you expecting the surveys to be done in say 2026? Are we doing them once? We're doing them twice, quarterly, because again, that's the other challenge is your population may shift dramatically in 6 months. I can tell you it has. So, but those are my concerns and questions, I guess.
Those are great questions. Thanks. Thanks for those. I think I want to allow the time here, since we have the CoreQ team, to talk about the kind of the rationale behind the hospice exclusion. And then also, if they don't mind, addressing whether states generally like combine the survey results for resident and family, because we are talking about surveying both, but whether they're combined and scored against benchmarks as a group or separate from what you see nationally or as the developers of the tool. Let's start with those two for our guests.
I could take a quick stab at that. I actually appreciate your comment about hospice. Hospice residents are typically excluded from surveys. That's one reason that they were taken out of this, for it to be a survey and a survey process that is similar to those used by the vendors that would be doing this. The second reason is that there might be different supports and different care given to hospice residents, and that could influence the satisfaction scores. And our goal is really, again, to have apples to apples. So if you have some residents that have different supports or more supports or less, that we're not getting what we want with the exclusions. But I do agree with you. When we get to smaller facilities, we're trying to have a very narrow line of trying to get enough scores back or enough surveys back such that we can get a score and that gets harder with the exclusions. So you are right about that, Peter. The second part of the question was, I talked too much and I've forgotten about the second part.
Well, really about when we talk about like measuring the results of the survey, do you combine patients and residents and families? Sorry.
So many states, there are a lot of states doing this, and a lot have done mixed with this, but none of them will say, hey, the resident survey will do even if you don't have enough family survey. What we actually need is enough family surveys back and enough resident surveys back. Some states will use those as two different scores, others will average them. And why we like both back as independent samples is there's a lot of work that's shown that families' view can be very different from residents' view, and they can and will give a different view of satisfaction. So if you just use one, you might be getting a somewhat biased picture of satisfaction in your facility, but there isn't any concern about averaging the two, so long as the samples of both are robust and you have the 20 returns and a 30% response rate.
Oh, go ahead. You're on mute. I think you might be Peter.
I guess that was my question is what is the state going to choose for their measure? You know, we're talking about money here at the end of this whole process. What are we being measured against? And is the playing field kind of fair? Because if you're a small facility and you don't have enough eligible surveys. Do we use the family survey? Do we use a combination of those to determine, you know, to put everybody on an even playing field? Because otherwise, I applaud the attempt of trying to get satisfaction surveys done, and get them done well. But again, what is the playing field we're all playing on? Because again, as a smaller facility, you will end up being, I mean, between residents with low BIM scores and hospice, I don't even know if I could field get 20 eligible surveys at this point in this moment from residents. So if residents are the only benchmark and families aren't included, then we have a whole other problem. Okay, now we are excluded just simply because of the population we take care of. And that is the concern when building this, you know, benchmark that we're all going to be using to measure, you know, back and forth. And even in the 5-star rating system, there are facilities that haven't been able to supply enough data, thus for good quality measures. Therefore, they're, you know, it says right on the site, no data available. So that information can't be used in the computation of their score. So that's my concern just on that, given the fact that smaller you are, the quicker in the numbers of excluded people, it becomes a problem for all. And a lot of facilities are smaller. I mean, they're not huge 200-bed facilities in the state of Maine. Not as many as there used to be, so.
Yeah, thank you. And we anticipated, and we kind of want to hear this feedback today. We are not, we will get back to you on the response. We want to hear the totality of like kind of the feedback on the methods being discussed, so we can continue to finalize the proposal around what is the minimum number. Is it going to be the same minimum number that you just heard from CoreQ? Is it going to be, like you're saying, across both groups? But we wanted to hear the feedback as to, is the minimum number the concern? Is it, I mean, we have a question about phone, which I'll get to in just a second, but I wanted to go back to one other question which you raised, which gets to minimum number as well, is the state going to tell you or that you have to do it only once a year? Or I'm going to turn back to Dr. Schwartz and Dr. Castle, because I think there's other states where they've basically said, you know, you might do the survey twice a year. You might do it in order to achieve those minimum numbers. So I don't know if they could give an example. You've told me before, but tell the whole group about some of the examples of how states are looking at getting up sample size by doing multiple survey sessions.
Yeah, for this, the issue that we come across most commonly is what's brought up here, that the sample size for the smaller facilities, and you are right, even with Care Compare, with their quality indicators, that comes up there too, and nobody really has the great answer to that. But what can be done with satisfaction surveys is that if your collection period is a year, so smaller facilities, I'm not saying Maine's going to do this, but the smaller facilities could have 2 windows of opportunity to collect information, and that would make the number of possible returns larger. Now there are some states currently looking into that. I don't know if we are in this case, but that's all geared towards helping the smaller facilities get a CoreQ score.
Yeah, so some things we're considering, definitely. Appreciate that. Could we talk a little bit about phone surveys? Do you want to talk a little bit more about why the recommendation from your teams are for the mail surveys and not phone surveys?
Yeah, Lindsay went into a great detail about the survey being validated by NQF and the testing that we did for several years. And all of that was actually by mail. And so the benchmarks that we have, the scores that we have, the testing that we have, it all relate to a survey administered by mail. And what we found since is other modalities can come in with different scores. And I've got nothing against telephone surveys at all, but there is the sense that some telephone surveys can elicit what's called social desirability. That if you're asking somebody that's nice on the phone, do you like me? They'll go, yeah, I like you. And so you can get a different answer by telephone than from mail. And if we have multiple facilities in the same group for comparison, and some are collecting by mail, and some are collecting by internet, and some of them are collecting by telephone, and they have different biases or different propensities for different scoring in each, then you don't have the apples to apples that we would like. And I would think that for most folks on this call, you'd like all to be compared with the same metrics, with the same possibility of getting a score of 100 or whatever it would be. And the way of doing that is by having a uniform survey administered one way. And I think that mail is that way because all the testing was done that way. I hope that helps with that. Again, nothing against telephone surveys, but then also what you get into with telephone surveys is some of the vendors can calculate response rates differently. How do you acknowledge that you've contacted someone in a numerator and a denominator? Is it if you give them 5 calls and they didn't answer? Are they there? Do you include them at all, or is it somebody that answered the phone and then refused to give you an answer? That kind of thing is not standardized a lot with telephone surveys, and would find probably the same thing with this initiative if that we were to use telephone surveys.
But, and again, this was something we were curious your take on. So thank you for the folks in the chat and for asking the question. We'll still consider that. This one I don't know the answer to at all. Could skilled nursing facility or short stay residents be surveyed if the person had been in the building for 100 days, or are the surveys exclusively for long-term care residents? Is that something that's in the guide in the user manual?
I actually don't think that is in the guide or the user manual. That's why I'm humming there. My instinct would be that the idea here is that they have experienced your surveys for 100 days or more. If they've experienced your surveys your care in the building for 100 days or more, that they should and could be eligible.
And they would likely max out their skilled benefit at 100 days anyway, right? But if they came on skilled, went to long-term care, came off skilled, that's just at that point considered a different payer, right? And there's a possibility to open it up to all payers. You said Dr. Schwartz and Dr. Castle, right?
Yeah, pretty much everybody else that does this has all payers. A lot of rationale behind that, but mainly the care is probably uniform for all the different types of resident payers that you have, and by including them all, you get a bigger sample size. So I don't know anybody that just goes after one select group of Medicare or Medicaid or private pay.
But I think the question, at least the way I read that question, it's for the short-term Medicare person, you're never going to get 100 days. I haven't seen a 100-day resident in a couple of years now. Those surveys, you make a distinction in the questions in Core Q between long-term care residents and short-term care residents. So a short-term care resident wouldn't need to be there 100 days for a survey to be issued. It would be issued upon, I would assume, a sort of a discharge process for the short-term residents who are there for rehab, going home. At least, because Nick, I used your system a long time ago, and that was when I recall the short-term process being is that there was a differentiation between long-term care residents and short-term care residents, at least at that time, where if you're coming in for a broken hip, you're never going to be there for 100 days unless you're going long-term, which moves you from a short-term person to a long-term person. And the questions you want are different because you ask a question about discharge planning in there, and that would be a short-term person question versus a long-term person's question, because most long-term people do not discharge at any point. So I think that's kind of where that was going is, is there a measure going to be measures for the short-term people versus the long-term people who have been there for over 100 days? Because you were right, the 100 days, I understand you're looking for consistency, but for the short-term people, you're also looking for satisfaction, but not in the same way as the 100-day person.
So actually, I agree, and now I know why I recognize your name, Peter. We have been in contact before. Hi again. We do have a short stay discharge survey, and that is in acknowledgement of the short stay folks can and will be possibly on a different unit or get different types of care, and that addresses their care and also the discharge process. And we found that can and is distinct from the long stay and the family member survey.
Hey, another question that's come up. It was basically, will the state people have access to survey responses? And we haven't. My general thought on that is not person level. No, we would need your scores and potentially your numerator denominator to know that you got to the calculated score correctly. But we have not discussed seeing person level results from these. But we can take that question back in case other folks had other ideas on the call. And we actually wouldn't be collecting data on we wouldn't be asking for that or anything really about your additional questions. We might want to have you all talk to each other and think about like what additional questions that you've all added have been really valuable for your facility as just part of general quality improvement, but the state would not be scoring or looking at your additional questions that you add on top of the base ones used for scoring. Those would be up to you. Amanda, do you want to add anything?
I just wanted to say, Maureen, I see your hand up.
Yeah, that was me that put that question in, Amanda. It's Mo. So I think what I had raised concerns about before and just wanted to make sure that it was discussed is that facility level data available to the licensing and certification survey team was the question that I think we wanted to have clarified, make sure that the survey team would not necessarily come in with that data as they walk through the door with, potential areas to be addressed. So,
like where that we give the data to the folks
right.
who are going to come in and survey. Okay.
Right.
Yeah. Okay, that hasn't been discussed, but let me
okay.
We haven't
Thank
discussed
you.
that, but let me take it back. Yeah.
Thank you. And I know we've had this conversation. I've had it with several of you, and I'm seeing a lot in the chat too about the mail or other ways of connecting. I had somebody say to me, well, why don't we just use SurveyMonkey? And I understand that not everybody is on the computer, but a lot of people are using alternative forms. So just again, to reiterate that, request consideration of that.
And Jake, I see your hand up.
Yeah, and I'm going to echo Maureen briefly. With the set of the core questions being so limited, I know our process dives into multiple different departments, multiple different experiences here within the home that we're currently surveying our residents and their families on. I would see this, if it is accepted as proposed, this would be an additional process for my home, in addition to what I will probably keep in place to maintain the high level of customer service expectations that I have for my home. So as you're flushing out the final details, as it stands and as you propose it, it would be an additional ask of me and my team at this time as proposed.
Thanks for pointing that out, Jake. That's good feedback. So it sounds like folks that are already have a survey, you know, being implemented. If it's by phone, you probably wouldn't stop doing that. You just have to add this on as well. There was another comment in the chat, and it's a little bit about this method, but I want to share it because it's a little bit more specific. At the Cedars, we use We Care Connect for resident, family, and staff surveys. And it sounds like those go out first via text, then via email, and then if there's no response, then finally a phone call from the vendor to get an increased response rate. So I don't think that text or email had been brought up before that. So I just wanted to mention as a different variation. We appreciate the input and the really good questions. What other questions do you all have, or even if it's on the same topic, if you've got a different take or a different perspective, something else that you're already doing, you know, we want to hear that. We want to hear that now, you know, while we can still use your feedback to kind of influence future.
I think it would be good for those of us who don't have a regular survey process to know from the others who are here, maybe throwing in the chat, what they do, what vendor they are using currently. Because like with Jake mentioning what Jake was saying about this has to be an addition, you know, again, I want to make a good choice overall to get the benefits of both QuEST and more detailed information. It would be nice to know what other people are using, but again, back to how often is it going to be, what are the requirements? The sooner we know, so we know what vendors to ask, what vendors what they need to provide us with. Because now you got Jake, who's made a good point. He's got to spend money. He's spending money on one survey. He may have to spend money on another survey to participate in this. And I would rather spend one set of money to get both benefits versus, you know, reinventing the wheel a dozen or so times. And the other question I have for Nick is, if the surveys come through paper, but can they come through the internet now? Is that possible for the surveys to be delivered that way, given the fact that that's the way a lot of people, even people in my age group of the 57-year-old, does not want to take another piece of paper, which may or may not get delivered to my house these days? And is it possible to get the results that way? Because I understand the phone thing. It's very, your voice is quite lovely, and it will influence the survey just by the voice alone, whereas a survey will not, a paper or an internet survey. But is an internet survey or a text survey, them delivering that survey that way, going to be acceptable as part of the process to do QuEST?
I can't tell you for this initiative whether that will be acceptable or not. I can tell you that we've done surveys with through the internet and SurveyMonkey, etc., request of facilities, and I'd say over the years, yeah, the response rates have gotten better. They're still not they're not as large as the mail survey that we use. And I don't know necessarily the reasons behind that. Computer literacy, internet availability, whether the facilities involved have collected the correct email addresses or whatever information would be needed. But yeah, the survey has been used that way. It just hasn't performed greatly. And again, getting back to the fact that it hasn't been tested that way, I don't know the bias involved with that. And I agree. This is sort of somewhat contentious. These different modes of collecting the surveys have different costs. That they have I can see by the chat people have different views on them. I do agree that the mail surveys over time are not doing as well, but I probably think that comment has to do with the CAP survey. When you get a 54-item questionnaire in the mail, I don't think anyone's going to fill it out. The advantage of the core Q is it's short. And then getting back to Jake's question there, even though the core Q is short, we like the questions or require them to be first on any questionnaire, but any vendor can add additional questions to that, and we actually advise that so you can get additional information for quality improvement. And I can tell you that in any other state or all other states that have done this, the vendors are able to do this and actually do it very well. As far as the vendors go, the large vendors do a great job with administering core Q, getting the scores back to you, and the response rates are usually typically really quite good.
Yeah, and I'll jump in on the vendor part because we've seen them chats. Like, so you're welcome to share with each other the vendors you're using. That the department from our place isn't going to get involved in that sort of choice, up to your facility, but we're happy to help facilitate those connections. If we can take that back of how we can make sure you have that space to share. But in the chat is one way to share. Some folks have shared their vendors. And then also some notes from Maureen about if you get any pushy outreach on vendors, that she's suggesting you could reach out to the MHCA if you need some support there.
Yeah, just to let people know, a lot of members have received some pretty high pressure sales calls, basically saying, if you don't sign up with us now, you're going to lose out on this money. So please don't get caught up by that. If you get those pressure calls, feel free to reach out to us anytime.
Thanks so much. And just again, like why this is so important to get your feedback today is, as you all know, or likely know, that this level of detail, the final decisions, will go in the rule, the main care rulemaking that's forthcoming on what's going to be required for the quality bonus pool in 2026. But also we're going to communicate that in a more friendly way too, via the QuEST initiatives to you. So you don't have to necessarily read the rule, but that is why we're at a good timing to kind of solidify these decisions. Again, I think it'll be something we continue to evaluate over time, but we know you need some level of information as soon as possible so you can start making your plans with your vendors for 2026. So with that, Amanda, I guess, do you want to transition to the closeout, or do you want to add?
Sure. I just wanted to share one more comment that made it into the chat, just because it's a slightly different perspective. And that was from Janelle. Thank you for sharing, Janelle. Glen Ridge, which is a 100% dementia nursing facility, if they excluded residents on hospice and the BIMS criteria, they're very nervous they wouldn't have a large enough sample size. So just a slightly different take. So I wanted to make sure that got in there as well. Sorry, I see a question too from Dr. Weary. Dr. Weary, did you have your hand up?
Not intentionally.
Not intentionally. You were just waving to me. Well, it's wonderful to see you.
Yeah, good to see you as well.
All right, and yes, I am pulling that up. 1 second.
Oh, do you want me to do the other announcement slide first, the Health Info Net?
Sure. Yeah, if you want to do that, that'd be great.
Okay. So while we have you, we just wanted to close this out with another update, or just another process improvement update here. So this is separate from Core Q, but since we're all here, taking the time to let you know that by tomorrow or on Friday, you'll get an email that's to the QuEST listserv again to clarify some ways that we can improve the scheduling process with Health InfoNet. One of your other 2025 requirements is for your organization to have a technical assistance meeting with Health InfoNet, the statewide health information exchange. I put the little excerpt here on the slide from the resource document that Amanda had sent out earlier this year to try and describe this requirement. Again, it's also in the main care rule as an active 2025 requirement. Some facilities have already checked this off. Others have been having a little bit of scheduling bumps with Health InfoNet, and we've connected with them and are going to, again, put out an email with a kind of smoother process, hopefully, for making sure all organizations are able to get their Health InfoNet technical assistance meetings scheduled before the due date of October 1, 2025. So we're going to really focus the next June, July, August, 4 months on organization level meetings with Health InfoNet to make sure everyone can schedule and get in for this requirement, and no one is feeling stressed that they won't be able to get a meeting scheduled, because scheduling's hard, especially in the summer. So we're going to request again that it's at the organization level, which is permissible to meet the requirement for the next 4 months, and that's going to be the ask. There can be other meetings for Health InfoNet technical assistance after October or just as part of general operations, but we're going to try to focus in on the organization level to make sure everyone has time to get these scheduled in the next 4 months. Again, thank you to those who have already checked this one off. I can't see the chat. Let's see. Is there some questions about this in the chat?
Yes, I asked a question. Can you just clarify, Olivia, when you say organization, are you talking about the individual nursing home? So for example, that each nursing home versus the organization, such as the regional director or somebody else from, say, the corporate office?
I mean, the company, basically. Or Amanda, can you translate into terminology that's more commonly used here?
Yeah, sure. So, for instance, if North Country, had a representative representing all of their nursing facilities, that would be fine. That's the intention, or First Atlantic or National or Maine Veterans Home or any of the organizations. Does that make sense a little bit more, Mo?
Yeah, she said yes in the chat.
Yes.
Oh,
Yeah, thank you very much.
and you can invite others. Again, like we're scheduling at the organization level, but we encourage you to identify who to join that meeting from the different facility locations. Again, that makes sense for this initial meeting. So that's up to you who else you include, but that's what we're trying to get up to that level for the making sure scheduling works out for everyone.
Olivia, there was also a question, as an independent provider, can you assist in getting a meeting?
Yeah, so the email that'll go out tomorrow or Friday is intended to help make sure that meeting scheduling goes smoothly. So it'll have an easier way to request a meeting if you've had any trouble already with that, and then that should work. If it doesn't work for you, I mean, I talk to Health InfoNet all the time, and I can make sure that you don't have any trouble. But ideally, the email tomorrow or Friday will help everyone do this quickly. We want everyone to be successful, so we want you to be able to get your meeting scheduled. And great.
Perfect. Other questions about Health InfoNet? Feel free to come off mute, or if you're shy, you can definitely drop them in the chat. Just to reiterate, you'll be getting more communication on this very soon. So we recognize some folks have already reached out to Health InfoNet, got those meetings done. Others have not heard back yet. We're working through any kinks there.
And if you already partner with HIN, you still need to do the 1 hour meeting. It'll just be probably more advanced or more targeted to what you can do to improve your current use of the tool, or just bounce ideas off of that they may have, how other people are leveraging the tool. So it's really for if you don't yet have a connection, if you already have a connection and aren't using it, or if you are using it and you still need to just take the meeting or do the meeting and learn more. And you are required in rule to track your attendance, I believe, with the Health InfoNet requirement. They are also tracking it, but it is your requirement to track your attendance at the meeting with Health InfoNet.
Yeah, you got that comment in there. That's great.
I'll just come off mute now. So I just want to clarify for that. I asked that question. If we have one person attending for our organization, how would I submit that for proof? Like if I attend for, 10, my own center and 10 other centers, how do I submit that proof?
So you would say
that it was completed from an organizational level.
Yeah, so you would just say, I attended on this date,
Okay.
and my attendance included these representation for these facilities.
Okay. Great, and just email it to the mailbox.
Yeah, I have to defer to Amanda. How are we collecting? Have we not sent out a request for collecting that yet?
I thought the intention was that they were just responsible for keeping it on file.
Okay, yeah, we'll get back to you. I think we
Okay.
were thinking, yes, we were thinking we were just gonna trust that we can audit to it if we need to, but we'll let you know if you need to actually submit something to us over email. Otherwise, just make sure you keep track on your side.
Thanks for asking that question, Emily.
And the email tomorrow will let you know the contact information for who can best schedule your meetings, Donna.
Are you doing this slide, Olivia, or am I?
Oh yeah, sorry. No.
That's fine.
Amanda is very organized, you all. It's me who's not. So so again, we want additional feedback. We're really thankful for all the feedback today and the calls, very helpful. We're making these decisions. Please email the shared email box there with any additional CoreQ comments by June 13th. Again, we want to make sure we have get the rule and this guidance as most right as we can the first time. So June 13th is a date that would be very helpful if you need to add to anything you've said today. And this, I'm turning it back to you, right, Amanda? Talk about your awesome survey. Okay.
Yeah, so yeah, just one last thing. If all of you would take a moment just to complete a survey, we're just trying to kind of gauge how the calls are going for QuEST, what we could improve, you know, what you like so far, what we could do better. You'll see there's a QR code on the screen. If you're a fan of those, that's really simple, just scan. I'll leave it up there for a minute. Or if you prefer a link to that SurveyMonkey, Chelsea can drop that in the chat box. Just as a reminder, if you have feedback for the CoreQ, just send that to the email inbox. This is for the overall QuEST call. So after this call, if you have other questions, of course, you can send those to the inbox, that odes.nifquality@maine.gov. And Chelsea's put that in the chat a few times. But if you could drop it in one more time, Chelsea, that'd be great. If you have suggestions on how to proceed with that CoreQ, again, send those to the inbox too. We'll post today's recording and the slides on the Rate Reform website, hopefully by the end of the week or Monday at the latest. I do want to put one more plug out there. We do have a SharePoint site that's it's ready, but we have had some technical difficulties with certain members of our task force accessing it. So before we share that broadly, would love to trial just a little bit more with some representatives from different organizations. So if you want to try out that SharePoint, just drop a note in the chat. I'm happy to share that out with you to give it a whirl for, like I said, some different reps from different organizations, and then we'll be sharing it more broadly very soon. We want to make sure that we work through all the technical difficulties before we expand it. We'll also send out the slides, speaker bios, and any other relevant materials via the QuEST email to all QuEST members, as we usually do. Thank you so much, everybody, for joining. We hope you have a wonderful rest of your afternoon, and we'll be looking for your feedback in that inbox.
I'm just going to hang out and leave the screen open for the rest of the time as folks may be completing the survey. But thanks, everyone.